discussion on this? Okay. Mr. Daniels, Mr. Wagner, then we'll get rock and roll.
All right, we're back on. Are you folks ready? Okay, 'cause I was waiting for actually somebody to be standing there in front of the, yeah, that was, everybody else stands there. We're ready. Okay, if you would identify yourself, your corporation, your position there, and you have 15 minutes, madam.
Great, thank you so much.
They come in.
Good afternoon. I'm Martha Harbin, Director of Business Development for the Southeast for Corizon Health. We're your current correctional health care provider, and we're here today to talk about the successful partnership that we've forged together with Volusia County since coming in 2005, and what we're going to do moving forward to strengthen the program to continue serving the people of Volusia County. Get over my nervousness here so I can talk and do slides at the same time. Okay, great. So who is Corizon? Well, you all know who we are because we've been here since 2005, and these are all the people who they on a day-to-day basis are staffing the medical unit at the jail. We have our health services administrator, Greg Phillips, who's kind of legendary for his 11 o'clock midnight texts and emails to check on the outcome of a patient, who was needing some assistance when is in the infirmary needing some type of assistance. We have our site medical director, Dr. Jill Pineda. She's been serving you admirably. She is known for coming in on weekends and after hours to do sutures and take care of other emergent conditions that otherwise you'd be transporting somebody to an emergency room because of the hour of the day that it is. We have our site director of nursing, Alicia Smith. Another person who comes in all the time as needed to ensure that there's continuity of care, good patient care. We're keeping an eye on the patient's outcomes. You also have, well, she's not here with us today, but Corizon's Nurse of the Year for this region. She's just going to be named today as one of your nurses at Volusia County. Barbara Turner. And she has been at this site since the day one that we started up. She's worked here continuously, has never taken a sick day. Has gotten a bonus every year that we award a bonus for, perfect attendance, basically. She's gotten that every year that she's been here. Really an impressive person. Works very hard, very organized. I don't want to get too much off track on our time. There have been some differences to Corizon over the years, though. We have a new name, Corizon Health, and we have new leadership at the top of our company. We are a physician-led company. Our chief executive officer and our chief medical officer both come from a public health background. We view ourselves as very much part of the public health continuum here in Volusia County. We have organized a business model that's kind of unique, that is unique in correctional health care, in which we call it joined at the hip. The clinical and the operational folks work together to ensure they're trained and they're empowered, and their job is to make sure that good quality care, patient safety is being practiced and observed, but at the same time being a good steward of the taxpayer dollar. So they work hand in hand. It creates a little bit of a tension, but that's a good tension because you don't want operational concerns taking advantage of clinical concerns, but you also don't want to be over-treating or doing things that cause expenditure of funds that are inappropriate. So this has been a very successful model, and it's working very well. And we have, at a regional level, Carl Dowd, who you also know, he's in and out here all the time. He provides operational oversight to the site. He's a resource to the people on the ground. Jane Lackner, our Vice President of Operations, who you'll hear from soon. You see her all the time, we're in and out. And Dr. Gonzalez, our regional medical director, she too is a resource to the site, has very impressive credentials, and she's here to collaborate and to be a resource, to help review charts, to make sure that the care is, that we're taking care of folks the way we need to be taking care of them. So I'm going to ask Dane to come up now to talk about kind of the program as it was and how it, where it is today, and some of the reasons that we cite for our success of the program.
Good afternoon, and thank you very much, Martha, and thank you everybody for inviting us here today. Oh, it worked good. I'm not very good at these. My name is Jane Lackner. I'm the Vice President of Operations for Corizon Health in the Southeast region. But what I am is I'm a registered nurse, and I'm passionate about inmate health care, as is the rest of my team. I mean, we do it 24/7. We love what we do. I put some stats up. It's not all of the stats that were put up earlier, but I just wanted to show you that the average daily population in 2006, similar actually in 2013, it's been up and down and all around. Our FTEs have pretty much stayed very, very much the same within an FTE or two, but the added FTEs we never charged back to the county, and that was a savings of $45,000. We had to bring them in just to do what we needed to do, a dental assistant, things like that. But what I wanted you to see is that with relatively the same stats in terms of the population and the team we had working in the facility, with our patient encounters with our providers and our nurses have gone up 54%, I'd say, since 2006. And yet at the same time, as you can see, our inpatient admissions, our days, and our ER runs have gone down substantially. And what I'd like to talk to you about a little bit is, how we do there and how we got there. And we do that by providing the tools to make good clinical decisions and really practice preventive medicine from the minute they walk into the facility. Yes. So some of our tools for success. A comprehensive orientation. I believe knowledge is power. So we start with orientation, obviously, day one, and then we have a continuation within 30 days, 90 days, but it's continuous throughout the year. Every time we have a good outcome, or a bad outcome, or a bad moment, or a great moment, we take a look at it, and what was so great about that? How can we implement that and use it everywhere else? Our orientation is also very, very specific to the discipline, whether it's the doctor, the nurse, the administrative, the clerical team. Everybody has their own type of orientation. I said we practiced preventive medicine. We had noticed that at some point across the region, we had a couple of people going into the hospital for very high blood sugars. And when we looked at the charts, these were people that didn't walk in saying they had diabetes. So Dr. Kennedy, he used to be the regional medical director, he's now in charge of the whole Southeast region. He said, okay, this is what we're going to do. And he put out parameters, and we do AccuChecks, blood sugar checks on everybody at their history and physical. And we're going to try it just for a little while, and it turned out we can't. We have to keep doing it because we're picking up another 10% of people that never knew they were diabetics. And we're getting them on the correct meds and taking good care of them and hopefully avoiding hospitalizations. We have a daily debrief every morning, and that's something relatively new. We do it regionally, and every team that I have does it at the site. Every morning they get together, all disciplines, they sit down, they talk about their top 10, their sickest patients. They talk about whose appointments were made, when they're going out, how they can, and the whole part of that is so that nobody ever falls through a crack. That's what we do. We gather together and we sort of make a net in a network, and we keep everybody on the right track. Collaboration is a big one. We collaborate with each other regions. We collaborate with corrections all the time. As a matter of fact, it was a conversation that Dr. Ford had with me that made us go back and relook at our detox program. And we really beefed it up after a conversation with Dr. Ford. She just saw some things that I hadn't seen, and we were able to change it up. Our management is extraordinary. I mean, it starts every morning, but our regional medical director, Dr. Gonzalez, has a call twice a week with all of her providers. They talk amongst each other, they offer suggestions, they really hone in on what's going on. And we do retrospective reviews, like how could we have done that better? Oh, that was great, how did you do that? We have very good partnership with Halifax Hospital. At the moment, we had developed a program with Dr. Carbonet to work with us to treat our pregnant inmates that come in on opiate drugs, because they have to be maintained on methadone so that nothing happens to the baby. So she's really watching them, taking care of our really high-risk patients over there. On top of that, they allow Dr. Gil-Pineda to do courtesy rounds. We have an electronic portal with them. We work with Dr. Mosley, the hospitalist. He's like our primary care provider at the hospital. And all of these are tools so that we can get people out to where they need to get to, back into the facility, so we can take care of them there. And we're getting another 5 or 6 beds, and that will really help, because we're managing 1,500 inmates with 6 infirmary rooms that will be expanded very soon. And we're very excited about that. Those are some of the tools that we used, and I just wanted to say that that's sort of, I think that level, the Southeast has always been looked at in Corizon as really a best practice group, and that's what we do. And I think that footprint that we made has been able, our little footprint is what brought us to get even a larger footprint within the Southeast. I put up a screen, all the colored counties in there are where we have facilities. We take care of 85,000 patients in Florida. We have 84 sites, which 75 are DOC facilities. We have 8 jails, 10 sites, and a sexual assault treatment center in Fort Lauderdale. What that really helps with is we're there in case of emergencies. If something happens, like the Escambia, what was that, an explosion. We were there, and we were able to we were up at Volusia County. We were able to help them out and get a whole bunch of patients into Volusia County and take good care of them. With the DOC as a partner, very recently we've been able to transfer, we had a patient who was actually sentenced and ready to go to prison. He got sick before being transferred. He wound up on a vent in the ICU. And we had our clinical team from the DOC come down to meet with them over here in Halifax. They worked together. They actually were able to transfer him on a vent over to the hospital in the DOC. And it was a really good thing. We found out he wound up being hospitalized again into another trauma center. And, you know, again, that was a great partnership deal. We're working on a 340B drug program, which is a federal program that discounts, gives us cost reductions. We're going to use it for HIV medications. That can save about $50,000 a year, I'm thinking, based on the spend that we have for HIV medications in this town. We're able to do that because of our partnership with the DOC, and that is now a contract with the county that the county health department has with you. Let me think. All right. Those are a lot of the things that we've been able to do here. I'm thinking if there's something else that I wanted to tell you here. We love being here. We're passionate about it. I love Daytona Beach. I like the land. And with that, I'm going to have Martha talk to you a bit about the future.
Thanks, Jane. I hope our passion and our enthusiasm comes through despite our nervousness and the shake in our voices sometimes, because these are not just healthcare providers that work in a correctional setting. Our team are correctional healthcare providers. It's specialized correctional healthcare providers, and it makes a difference. I know, we go around the state and we're frequently up against the same competitors for business, and I hear the things that they say. And I know that it's easy to take snapshots in time or to pull out a number here, a number there, and use that to make a point around it. There's always another side to the story. There's usually always a very good reason for some of the numbers you see or some of the outcomes you see or that sort of thing. And I hope we'll have the opportunity to address any concerns, any questions, any issues that may have been raised in the question and answer period of time. I want to talk about what we're going to do moving forward. If you make a decision to transition, you're going to have quite a bit of time, probably a year before the site's back, working smoothly and you ironed out the wrinkles and that sort of thing. Or you can keep going with your proven solution with Corizon, and we can get going with some new innovative things to make efficiencies even better and to make sure patients even better. We've developed an expertise on the Affordable Care Act, so we'll be able to guide you through it, whatever comes down, whether it comes from the state or the feds at Affordable Care Act, looking to recoup costs anywhere that we can. We're going to bring in the Correct Tech electronic health record system. This is important. It's a standalone company, so even if Corizon's no longer your provider, you keep Correct Tech, you keep all of that. It's not that your system won't be pulled out if your vendor pulls out. That's important. The Intermedics prescription and insurance reconciliation system, within 2 minutes, even using aliases, we can get every prescription and whether an incoming inmate has insurance coverage for their prescriptions. That's so important because a lot of times where you have a complaint or you have a concern, it's because somebody wants to continue their meds and we're ethically bound to confirm that those are their meds, and the family's not always cooperative and the records don't always transfer. So Intermedic's going to let us do that in 2 minutes, pull that up. Tremendous savings. Running out of time, so what I just want to do, I was going to have Jane come back up and close, but we're asking for your business. We're asking for you to continue having confidence in us, working together with you hand in hand to keep this strong program moving forward. Thank you.
Thank you very much. All right, how long will we need to bring everybody in now? Just a few minutes? Okay, let's go ahead and bring them in. Okay, do we have the leadership from each of the organizations here? From Armor, CCS, and Corizon. I know Corizon's here. They're just here. There they are, and I guess everybody is present. Okay, cool. We'll start off with Ms. Kuzak. You have your light on, ma'am? Questions? The floor is yours.
Thank you, Mr. Chair. Thank you for coming here today and wanting to continue to do business or wanting to start doing business with Volusia County. I have some questions, and I guess maybe I'll ask the same provider each of the questions.
You have the floor. It's your call, ma'am.
I want to talk about from a legal standpoint, I'd like to know about your history of litigations and incidents in the facilities in which you represent. And I guess we can go in any order that you want. My call then would be Armor.
Just to confirm, is it okay if an individual who's very specific to that answers the question for us? I mean, our COO?
Yes, for me, that was who I would want to answer.
We've been in business 10 years. We have averaged about 20 lawsuits a year. So we have just about 200 lawsuits in our 10-year history. As I mentioned earlier during the presentation, well, first let me back up. 80% of those are pro se, which means they don't have an attorney to represent them. And 95% are resolved either dismiss the summary judgment or go away for some other reason. We have about 5% that end up in a settlement. And as I said earlier, the two types of settlements, there's ones where we realize we made a mistake and we work quickly.
How many have you had within, say, within the last 5 years that you realized you made a mistake?
Well, we have 30 total, so I would, in the last 5 years, I'd say maybe 18, 20. Company-wide, yeah, it's company-wide.
Company-wide.
It's across, we have 44,000 inmates that we take care of. We're much smaller than the other folks who are here, so our numbers will be big.
Aye.
Is that okay?
That's good, that's good.
Any other questions on those? We've had no judgments.
No judgment.
No judgments, no matter.
Then, do you want me to ask all the questions I have of Armour first? Because these same questions I will probably have in some form.
Well, it is totally, you have the floor, ma'am, and you may ask.
So we have no procedures to how?
No procedures, because believe it or not, the questions that you may ask, Ms. Denny's may ask, or I may be asking, or somebody else may be asking, so actually, you are asking some of the questions I was going to ask, and so I'm writing down notes.
Okay.
Right. So
My
please,
next
you have the floor.
question would be about the electronic records, medical records.
Yes, ma'am.
Tell me about your system.
We use two different, we looked at designing our own, and then we thought, let's not do that. Our expertise is delivery of healthcare, and we thought if we lose a contract, then we could say to the client, well, we're going to take our EMR away. So what we did is we went out and negotiated, we looked at all the EMRs on the market, and we decided on which one we thought was best for the business that we did, and we went out to those guys and we negotiated a contract with the A, most favorite nation clause, so nobody has a lower price than us, and B, we made them agree, or we got them to agree that if we lost a contract for any reason, that they would agree to keep their system in there at the same rate that we negotiated. So the client, there'd be no stoppage in service. You could continue on as long as you wanted with that EMR system. So we use two different systems. We use one called CoriEMR, which is built from the ground up just for corrections, and we use CorrectTech, which also has a doctor's office component, but it has a corrections component as well. We use CoriEMR most. CorrectTech is one that we only have in a handful of sites. So that's CoriEMR is the one we use. We believe in EMR. We have customized each of those to meet the standards that we have in place. So somebody may have that system in another jail, but if it's not Armour, it's going to be a different product than what we have. We have a lot of triggers and things that we have built into that is not in the regular system.
So then, if you have a client, an inmate who is coming to you, could you and have had been in a system someplace else? Does your system provide transfer of those records?
It can. No system can unless you build that interface, and this system can build the interface with any system. We haven't had any issues with that thus far.
I want to talk to you about your mental health piece.
Okay. Can I get our mental behavior health, because that's something I can.
Yes, ma'am.
Thank you. I want to talk to you a little about the bridge program for psychotropic drugs. Do you have something in place to how you deal with psychotropic drugs?
Currently, we have the emphasis on the client and the community needs. Right now, policy-wide, anyone who's discharged from the facility, we give them a 7-day supply or a prescription for medication. Working with SMA, we looked at their psychotropic, their pharmacy that they had, and ways to maximize that specifically here for Volusia County. When we emphasize the continuity of care, since they are the community providers coming in, we pretty much would know what medication is the community standard. So working with their pharmacy and perhaps some cost savings. When you said the cost of psychotropics for the aggregated cap, that would probably be reduced with utilizing their pharmacy.
Ms. Kutek, one moment. For everybody in the audience, that if you're going to speak, you have to identify yourself and your position. We are online, and not everybody knows who you are. Matter of fact, I don't know who any of you are. So you'll have to identify yourself and your position, and then answer the question. Okay, I'm sorry, Ms. Cusack, you still have the floor.
Thank you. When would the decision be, are there guidelines that you use as to when you would make the decision to call Stu and Mothman and to proceed with the mental health piece? Is that at the beginning of entry, after an evaluation? Talk to me about how would you work a program through?
So I'll just identify myself for the record. My name is Maria Brooks. I'm the Corporate Clinical Coordinator for Behavioral Health. Actually, the catching at-risk individuals starts at intake. So we have a pretty comprehensive screening that identifies at-risk individuals and symptomatic individuals at booking. Those are typically trained by our medical staff. And it's pretty structured, and it's based on 30 years experience as well as community trends and needs that we see at all our various jails. Once that's identified, there are certain risk factors. And if there's any question or doubt, they can always call up a mental health provider. We have on-call services, as well as a pretty structured guideline. Any form of safety, we'll place them on a safety precaution right away. Individuals with detox, so there could be the co-diagnosis with mental health and detox. We always want to work collaboratively, medical and mental health, but we always want to treat the detox symptoms first with that relationship. So right at the door, we're addressing mental health and substance use needs.
If a person comes in and is taking medication of some kind, tell me, and you're not sure if if that medication has been prescribed, how would you handle that? How do you work with that?
Well, if you don't see my passion, I'm very passionate about patient care and the delivery of that patient care. We do go some self-report, but we also have to identify the active symptom impairment. And sometimes people may be receiving treatment in the community. That's not the best. We always try to verify active medication. So we are at booking, getting a piece of information and contacting primarily pharmacies, because not everyone remembers their doctor's name. So we'll get the pharmacy. And again, if there's an active prescription, we'll call and get verification to start that medication. If the individual has symptoms of detox or report substance use, we always want to address the medical components first to make sure they're safe. If they're saying they're taking psychotropic medications while using intravenous drugs, I mean, we want to make sure the patient is safe before we start them on the psychotropic medications through the medical detox.
And your medical detox would, is there a period when they are on no medications?
Yes, there is. They're based on their symptom impairment, and can speak more to the detox per se, but based on their level of symptom impairment, the medication intervention is given, they're followed up, and throughout their detox, they're working with both mental health as well as the medical team. I don't know if you want to know more specifics about the detox.
I just want to know if a patient is there and you're not certain of the medications that they are on, or even if there is a prescription, so you don't have a prescription, but they're taking something.
There's
Do
a
you take
variety,
them off of all drugs?
variety of ways that we address it. Angela Guerin, Senior Vice President of Clinical Operations for ARMA. It's a variety of ways. It depends on the patient. If the patient can tell us what medication they're on and they know their dose, which is really the exception versus the rule, we pick up the phone and call the provider and get the order to continue that medication. The patient says, I'm on a medication, but I can't really remember the exact name of the dose. As Dr. Brooks said, we'll do our best to notify the pharmacy, get that information. But the most important thing is that we assess the patient here and now, before me. Are they symptomatic? Even if you can't remember what it is, if they're symptomatic, I have a good history coming, we're still going to pick up the phone, call the provider, and let them make the decision. Am I going to order something here today? Is it somebody that I want to see tomorrow? Or can it wait 3 or 4 days? For example, if it's a psychotropic and the patient says, I haven't had it in a few weeks, that may be something that we put off for 3 or 4 days. If it's a blood pressure medication, we're going to pick up the phone, get an order, and go ahead and initiate the patient, even if they can't remember the name of the medicine. So there's a variety of ways that we're going to address that based on that patient's presentation to us in the here and now.
And if I could just add, Ken Pullen, the Chief Operating Officer. if you're interested, there is a service that we can utilize where you can electronically identify what prescriptions that an individual is on. And it's virtually real, well, not real time, but it's very quick. So you can use that as well if that's something that you're interested in.
Angela
Thank you.
Gehring again, and the other piece that we do is if, because of recidivism or return to the jail, we do have a certain complement of patients that are there frequently. Obviously, the first thing we do is grab that old record and see what the plan of care was in their previous admission. The patient may not remember, but we have that record. And with your adding electronic health record, that's certainly going to speed things along.
Thank you. Corizon, I'd like to ask a question, is how are you dealing today with your bridge program for patients who come in with mental illness or who's on something? Do you take them off, or how do you process that system?
It's very similar to what you just heard. Person comes in, they're on medications. We have the benefit of having SMA working with us. And they pretty much know almost everybody in the community. So, however, it is true, most people come in and they might know that what meds they're on, but they don't know what milligrams say that they're taking. And we did price and suggest that we get informatics in here because within 2 minutes you can actually have any medication that they've gotten between here and somewhere in California, and you can make it within the last 30 days or 1 year, and it really is within 2 minutes you can verify them. And then it would be up to the intake nurse, who's ever doing your intakes, to do a very thorough screening, look at the presentation of your patient, and then get on the phone to the doctor and talk to the doctor about it, and it goes from there. But we do have medications at the site that we can provide immediately.
Okay. Tell me about your agency nurses. Do you have any?
I can actually say very proudly that we have not used an agency nurse in the jails in the Southeast region since 2007. I need people working in my facilities that are passionate about what they do, and I just haven't really found that agency engagement when they come to the site to actually, they're just not engaged. They're in there one day, out the next. So I work very hard to keep agency out of facilities, and not really. 2007.
I'd like to ask that same question to the other two providers. Have you used agency nurses, and how often, and what's your
William Kissel,
philosophy?
Vice President for Regional Operations. We do not use agency.
Regional operations.
For Correct Care Solutions.
Thank you.
Excuse me. We do not use agency nurses. Our employees are full-time or part-time CCS employees.
And the same thing for CCS?
We are.
Armour is the one that is.
I want to say, I had a brief deal with our CEO. Out of our 28 accounts, there's 2 contracts where we do use agency nurses. They declined. One of them is, last time I checked, was a total of about 8 shifts. Now, actually now, just 1 site. So, similar to our, everybody else here, we prefer not to use them, but when it comes to the part of just literally on a day-to-day basis to have somebody in there. They go through the same training, the same orientation before they need to be used. But certainly it's our goal not to use it, but I can't sit here and say that we never use agency nurses. So, because on 1 account site, I know we have. So, okay.
Would you say that it's pretty common that you use agency nurses?
Absolutely not. I think right now, the 28, and I'm looking at our finance gentlemen, I want to say there's now just 1. So absolutely not. I believe 2 years ago, the most recent statistic I had, I believe it was less than 2% of the overall FTEs, and that number is now down. So, no ma'am, absolutely not. Very rare.
One of the providers, I think it might have been Armour, that said that they would be having someone in-house to do the ophthalmology type program. Talk to me about that.
Ken Fulham, our COO. We do use in-house optometry. if that's something you're interested in. Absolutely. And let me just back up, if I could, just to clarify. Our proposal also would have SMA as our subcontractor for that, so we would have
Yes,
both
I-
folks. Okay. And
All
on
three
your
of you
bridge,
have-
we don't call it bridge, and it's just a different title, but we do have in fact, we won Program of the Year for our discharge plan, to make sure that when somebody's released back into the community, they have their medication, and hopefully by then they have an appointment so that they can follow up, so that they can stay on their medication and we drive down the recidivism. We have some pretty good statistics.
And finally, I want to ask one about the specialty program as it relates to OBGYN. Who wants to take that?
Kim Christie, Transition Coordinator with Correct Care Solutions, and if I could just go back to your question that you asked about the optometry. We did indicate that we've established actually a nationwide agreement with a company called Institutional Eye Care, and they included, we included in our proposal a letter of intent from them to establish an on-site optometry clinic at the facility.
All right, well then, talk to me about the last,
Specialty
the
services.
specialty
for
services,
OBGYN.
yes. I want to know about dialysis. And if you would be able to, in your company, provide in-house dialysis, or would they all be transferred out for dialysis?
We very frequently provide in-house dialysis services. We actually have a national contract with a company called Chardonnay. We understand that there is a current provider in there, although it would appear as though the volume of service at the institution is pretty low. But I believe the current provider is Fresenius. We had reached out to them about their interest in continuing to provide services at the facilities. And we've actually had some experience in other counties where we had dialysis chairs, but they weren't utilized to their fullest extent, where they actually had an agreement with other counties to bring inmates in to have the dialysis services, which ultimately lowered the cost for the county that had the chairs that really weren't being utilized to their fullest potential.
Any of the other two providers would have in-house dialysis? Talk about the dialysis program.
Also address your question.
Angela Gehring, Armor Correctional. Thank you, Commissioner Cusack, for asking both about dialysis and the OBGYN services. OBGYN services, absolutely, we bring an obstetrician gynecologist in to see the pregnant women and any gynecological problems that we might come upon. Typically, however, they may or that may or may not be the physician when they deliver. We'll work with whatever hospital or place that we're going to send that patient to for delivery. In the event that they're discharged prior to their delivery, there will be an appointment and that safety net set up for them in the community so that ultimately that patient can have a healthy baby. Dialysis, yes, ma'am, we do bring it in, do it on site, and we also would provide a nephrologist to set up that plan of care and continue with that patient.
Thank you.
Jane Lyson, the VPO Corizon. Dialysis, we brought that program to the jail, I think it was 3-4 years ago, and we do in-house dialysis at the facility. It's a lot safer for the community if you can do it that way. And the OBGYN, we have a nurse practitioner at the facility. She does about 8 hours a week of OB, care for our pregnant inmates, pregnant females with Down syndrome. And we also have a contract with Dr. Carbonet over at Halifax Hospital. And again, she works with our drug-addicted pregnant women who are even at more risk than, all of our patients are high risk when they're pregnant, but even more high risk. And so they are taken care of on-site, and then when they're going ready to deliver, they're over to Halifax Hospital. And we do alert her that we do have one, whether it's in her care or not. She'll take a look. And then we have Dr. Mosley, who's also watching over everybody in Halifax Hospital at the same time, so we have good care.
Thank you, Mr. Chair.
Good morning, Dr. Gonzalez, Regional Medical Director for Corizon. Just want to just mention attention pretty much what she said. Every time we have more women coming pregnant with high risk, and every time coming more sick or using any drugs, so we follow these patients from the time they're coming in. So we had a nurse, there's an OB nurse that is there 80 hours during the week. And she also follows those patients. So also we are on call all the time. So now the providers are there. They can call the provider anytime. The patients also have the ultrasound as soon as they get there to make sure the baby is all right and has no any other issues with the baby. Just want to make sure that you mention that.
Thank you. I yield the floor, Mr. Chair.
Okay.
Thank you so much. Let me just say, I appreciate all of you answering my questions, and this is a big deal for all of us, the community as well as the providers, and thank you so much for putting yourself out there to want to do business for the citizens, the folk that come to Volusia County. Thank you, Mr. Chair.
And Ms. Denny's, you have the floor.
Thank you. Do we have those numbers on the actual contract value for 11, 12, and 13?
These are our expenses. One is associated ADP. That's the that's just
average daily ADP is average daily population, and so yes, the average daily population, and the total is the total that we paid in contract. Okay, that's our final cost. All right. Well, the kind of starts. I just passed out something to council. If Marcy, if you could put that in the overhead projector, since it's all public record now, everybody has presented. This is a document that we were given in a meeting with staff, and what I looked at in, especially our current provider Corizon, what I looked at the base ADP, the average daily population, what the suggestions were, I was intrigued that you started out with 1475 when indeed the baseline is well over 1500. And I'm not sure, staff can maybe answer this. When we did these projections, did we give the ADP, or how was this presented when it went on for RFP?
They were given data that gave our historical ADP. They were given the ability to bid differently from what they saw.
Okay.
So they have that ability to make some sort of a reasonable estimate in the direction.
Okay, thank you. And here, I'm struggling with a couple concepts here before I go past this. We have the asterisk in the middle, the less specialty cost sharing included in the base rate, the assumed specialty cost. And I'm looking at the final, in 2013, our actual contract with Corizon, we ended up and paid 7.6. But yet the annual base cost in presenting in 2015 is only estimated at 6.8. And then you've got the cost sharing. I have to tell you, this is extremely confusing based on existing data, based on where we are currently. Looking at this and how you could forecast reasonably what the cost would be. And you're going to have to convince me why the specialty cost sharing is subtracted from the actual value. Obviously, two of the three vendors chose not to. I mean, the price is the price is the price. And why, in especially a for-profit corporation, which all three are, correct? All three are for-profit? That's a fair statement? In a for-profit situation, why, because 1.2 million, and we look at 2015 with Corizon, you take 1.2 million out of 6.8, that's what percentage? That 15, 20% right off the top you're willing to say we're just going to absorb? What am I missing? Somebody has to explain this to me, because I have tried to wrap my arms around this many, many times, and just when I think I understand it, I look at the numbers again and say, in the business world, I don't get it.
Mr. Robinson will.
If you look at, I'm looking at Corizon because they're our current provider, and if you look at 2015, you see the red, the negative 1.248?
I assumed, and hopefully they can correct me if I'm wrong, I think the assumption is from a government standpoint, it puts skin in the game, so they have their incentive is to save us money, because if they don't, they lose money. I mean, I think from a business standpoint, a government standpoint, in case I'm wrong, that's why you do that, right?
Yes.
Because if you don't find the savings, you lose money.
Exactly.
They find it, we both win. I think that's why you do something like that.
That's it.
Which is also why I would have concern, I mean, I would assume we would want the other two to do it as well as part of it.
Well, I'd really like to hear it from them, because we've also got the base assumed specialty cost, and I understand that that's a self-insured concept, so it's not a savings cost, it's either we're being overbilled to begin with. This is business, and this is business.
No,
Big
Ms. Denny,
business.
Mr. Robinson prepared that chart, and I think he's best qualified to explain.
Please.
This is John Robinson, benefits consultant for the county. What we were asked to do is try to do an apples-to-apples comparison on the proposals that you received. In doing that apples-to-apples comparison, what we did is we looked at your current arrangement with Corizon, and your current arrangement with Corizon has a part of the specialty risk portion as a part of their actual base price. The proposals that you received from Armor and CCS included an aggregate amount or a specialty amount, but it was not included in the actual base price. So what we tried to do is separate those out in giving you the actual costs themselves. In looking at the current arrangement with Corizon, the current contract for 2014 is based on 1,425 inmates average population for the month. Their current rate is $385.70. That equals a base of $6.6 million for the base price. In that base price is a part of the specialty cost. A part of the specialty cost, meaning that when you look at their contract, what they're putting at risk in that with that 6.6 million is 1.2 million. So that's included and embedded in their actual base cost. Different than what some of the proposals are, and that's why we tried to equalize it. So if we normalize that by saying that what are the actual specialty costs and what are going to be a part of that, then that gets it to the $5.4 million level. What we were asked to do is look at a base population of 1,550. Currently you're in the neighborhood of 1,510, and the exercise was, let's try and equalize it to see what happens at 1,510. That's the additional $80,000 in the current contract. The assumed specialty cost we assume for everyone would be the same. That assumed specialty cost is that 2.34 million, and that's approximately what it is today. Looking at some of the averages, some of the information you got has the total numbers at somewhere in the neighborhood of $7.7 million. So looking at this factor, it's going to be a little higher because of the $1,550. Now that specialty cost is the area of fluctuation. And you heard some of the comments on how the savings would be generated by some of the different companies that came up. So when we looked at the actual proposals themselves, that's the starting point. That's how it's done. That's how it's done today. Then looking at the proposals, Armor has their proposal based on 1,425 inmates. Their base rate is $339.65. There's nothing included in their base rate on the specialty costs. Now, they did say that their specialty costs would be $1.215 million that they talked about earlier in their presentation. The actual base of that $5.8 million we did not adjust because it's not included in the base itself. Their actual charges for the population that would be above, in their case, 1,475, would be about $65,000 in addition to their actual base cost itself. We assumed the 3.24 million, and there, the question that could come up on that is we did it for everyone, because we said that your cost would be the same no matter what it would be. And then you would have to have some discussions with the different groups as to how you would see them saving on that 2.34 million with some of the things they bring in-house, or some of the management functions that they would devote to that. To look at Armor it specifically said that 1.215 million would be a part of their actual specialty cost. So that would be part of that $2.34 million that you see here in the assumed specialty cost.
Okay. Okay.
That would,
Okay, I get it. I'd like to hear from the vendors here. Could I have Armor address this, the specialty costs, and then Corizon and CCS speak very briefly on all three on this? Do you understand my question?
Yes, ma'am.
Okay.
Bruce Till with Armor, CEO.
CEO of?
Armor, I beg your pardon, of Armor. A couple of things I'd like to point out. First of all, the adjustment for the population, 64,879. Typically, in every contract that we have, there's a variance of, and I'm sure probably our competitors as well, there's a variance of about 100 to 150. And what that simply means is if the population goes above 1425 or below that, we would not bill for that. So from the analysis perspective, frankly, that I think probably for all vendors would be removed. The second component is, that's what I alluded to earlier in our presentation, is literally the $1 million question. That now makes more sense based upon the article that I read. We did not anticipate, in regard to these specialty services, to be running anywhere near the $2,340,000. I tried to cite numerous examples in regards to, as compared to predecessors, our first year's performance. So when I sit there, and it makes a little bit more sense, you have a base contract, and that's where it comes in regards to the surprise at the end of the year. You have a contract, but then all of a sudden it's running, I think you said $7.6 million. That's why I was alluding to all the rebates that we've actually given back. So one of the things that we